Okay. Good evening, everybody. Welcome to this eve. We are lucky today to have Dr. Afrah AlBabli. She is a consultant family medicine from Eastern Province Family Medicine Academy, as well as she is a brilliant trainer. She is the leading of advanced course in our academy, and she has many publications. I'm with you, Dr. Anada Bunayan, the Family Medicine Academy leader. Thank you very much for being all of you here today. Thank you, Dr. Afrah, for accepting sharing in this webinar. We hope all of you to enjoy this evening. Thank you so much. Dr. Afrah, you may proceed to your presentation.
Assalamu alaikum wa rahmatullah. Thank you, Dr. Anada, for this nice introduction. And it's a pleasure for me to present to you tonight in this webinar. And today we're going to talk about emergencies in primary healthcare centers. When I first given this topic to prepare, I thought initially that I will, okay, voice is not clear. Okay, can you hear my voice now? صوت واضح. Okay, so when I was initially given this topic to prepare, I thought I will talk about the most common emergencies we encounter in the primary healthcare centers, mainly hyperglycemia, hypertensive urgency, bronchial asthma exacerbation, and things like that. But then I thought that these topics, the most common problems, are already covered in WADA activities. So I decided to cover something else. All our cases, I prepared 4 cases, all are from my practice, cases I've seen during last year. And I think these cases provide a good learning opportunities for us all. So I will share it with you. Hopefully it will be of benefit to you all. Just an observation from my practice. Since COVID started almost a year ago till now, I'm seeing more cases, more urgent and emergent cases in the primary health center. So I've seen more emergent cases during this last year compared to my previous 5 years working since I finished my program. I think maybe because of COVID, patients are afraid of going to the hospital, so they're coming to us more now. So we need to be prepared to face these emergencies. And I hope I will be of help to you tonight to help you prepare for any possible future emergencies. So you can stop me at any time. If my voice is not clear, please inform me. You can either unmute your mics or write it in the chat. And I want it to be as interactive as possible. So I will need your help in that. Okay, so we will start with the first case. What do you think this case is going to be about from the photo?
This is Buthain Al-Yusuf. This is maybe cardiac or respiratory, but from the picture, respiratory.
Respiratory, yes. Okay, in the chat, some mentioned asthma, but as I told you, because asthma is already covered in WADA activity, I will not be talking about it. COVID-19, we fed up with COVID to the maximum, so no way, I will not cover COVID. Okay, pneumothorax, PE, okay. So something related to the respiratory tract. Let's see. Chest pain is also covered in WADA activity. That's why I didn't include it in my presentation today. So let's start. First case, 30-year-old lady brought to the PHC by her sister, complaining of shortness of breath since a few minutes. coughing, nausea, and she vomited once. Okay. So this is the history. A patient came with respiratory distress. What will you do next? ABC, yes, Khadija. Okay, so respiratory distress, it's a possible emergency. So we go take our history, conduct our initial examination side by side. So the ABC, patient airway, she can talk in a hoarse voice, but cannot complete a sentence because of continuous cough. Breathing, she was tachypneic, respiratory rate 24, oxygen saturation was 100%. Chest examination showed decreased air in all over the chest. Circulation, her pulse was 106 beats per minute, and the blood pressure was 146. And what we could gather from the history during our quick assessment of ABC, that she is medical free, no previous history of asthma or any allergic disease, and that she was cleaning the bathroom when she started to have shortness of breath. She went outside, but shortness of breath didn't improve, so she called her sister and brought her here. And this happened like around 15 minutes ago. So how would you approach at this stage?
Assalamu alaikum. I think I need further detailed history about the chemical or the cleaning material she was using in washing the bathroom. Is it the first time the exposure? Is it the first time she's exposing to this detergent, let's say? So yes, I need more details. The activity she was doing is cleaning the bathroom. Maybe it's related to her respiratory symptom.
Thank you, Horia. So she was clearly normal, and something happened while she was cleaning the bathroom. So we need to ask more about that inciting event. What products she was using? Yep, correct. And for how long the exposure was? Was the exposure in a ventilated place or not? It was in a closed environment. All these factors can affect the presentation. So she said that she was using Clorox and a flush. So she was using a bleach and a toilet cleaner that can contain acid or ammonia. So anything come to your mind as a possible cause for her respiratory distress? Yep, chemical injury to the airway. Yep, this is the most likely trigger. What happened that when bleach containing sodium hypochlorite mixed with toilet cleaners, chlorine gas is released, which is toxic to the airways. So what is a chlorine gas? Chlorine is a highly used chemical, both in industry and society. And it was used as an asphyxiating agent during World War I, so it's a chemical weapon. Currently, sources of exposure to chlorine gas come from two main sources, either industrial accidents or from household exposure via mixing of cleaning products. And according to CDC data, 30% of chlorine gas exposure cases happen because of household mixing of different chemicals. So imagine a gas that is used as an asphyxiating agent. It's a chemical weapon, but it can be readily produced in-house by mixing of cleaning products. So what happens when someone gets exposed to chlorine gas? Symptoms and signs. If there is a low level exposure, chlorine gas is irritant to the mucosal membranes. So there will be lacrimation, nose and throat irritation, and excess salivation. With high level exposure, there will be dyspnea, cough, nausea, vomiting. All these symptoms were in our patient. And there will be dizziness, headache, chest pain, abdominal discomfort, and corneal burns. And there is also a risk of pulmonary edema. Pulmonary edema is the most common cause of morbidity for moderate to severe exposure. Usually occurs within 2 to 4 hours of exposure to moderate chlorine concentration or 30 to 60 minutes of severe exposure. It might require intubation, treated with fluid restriction and diuretics. And because pulmonary edema can occur late, patients with chlorine gas exposure should be observed for at least 6 hours post-exposure. Management. The first step for managing any toxic exposure is decontamination, removal of the patient from the contaminated environment. And then treatment is mostly supportive. We can use humidified oxygen, inhaled bronchodilators like salbutamol, with or without inhaled steroids. The prognosis is good. Majority of patients has a good prognosis, but smokers and patients who have airway disease like asthma are likely to have a permanent obstructive pulmonary defect. So our patient management. So when you are dealing with a case of respiratory distress, which is a medical emergency, it can progress rapidly. The patient might need intubation. The first step is to call ambulance, especially if you don't have the ambulance on site at your door. Sometimes the ambulance might take 15, 20 to 25 minutes to arrive to your center. So to be on the safe side, consider calling the ambulance early, just in case. It's better to be there when you need it than to need it and not be there until it's too late. And also ask for help from other colleagues in your center. Inform them that you are having a case of respiratory distress, that you might need their help anytime. And then our patient received hydrocortisone 100 milligram IM. And she also received nebulization of salbutamol 5 milligram plus budesonide 2.5 milligram with oxygen. She received the first dose. Her symptoms after the first dose, shortness of breath improved, but she was still coughing, and she was still tachypneic, but the respiratory rate decreased to 18 per minute. So she was given another dose of nebulization. After the second dose, she clinically improved, but she didn't want to stay for observation and signed DAMA and left home. This is another problem with COVID, that patients, once they feel that they are improving, that they are fit, they don't want to stay for long at the centers. They are afraid of acquiring infection here. So she left DAMA. I was preparing to transport her to the hospital because it was 3 p.m. I wanted her to be observed for at least 6 hours, but she signed DAMA. I called her that evening around 7 p.m. Her voice was still hoarse. She stated that her shortness of breath improved completely while she is sitting, but when she lied down, she had shortness of breath again. So she was having orthopnea, which could be a sign of pulmonary edema. I instructed her to go to ER again, but I don't know what happened to her later. So that was the case, the first case of a chlorine gas exposure. Do you have anything to share? Okay, Dr. Abdullah Nasser, he remembered one of his patients presenting with the same history. Yep. Would you like to share anything? Do you have any question regarding this case?
Yes, Doctor. Good evening.
Dr. Abdullah Nasser, good evening. Yes, share with us your case, Doctor.
Yes, I remember one case before I joined the board of family medicine. I think he's 17 or 18 male patient came to my clinic in the BHC complaining of severe shortness of breath and coughing. During the history, the quick history, as this history said, he was using Clorox and a flash to clean the carpet in the bathroom. Okay, and after that he gets this severe cough and shortness of breath. I did for him salbutamol nebulization. I remember three sessions or less. He's getting better, and after that I referred him to the ER. That's my case. Thank you, Doctor.
Thank you, Dr. Abdullah, for sharing. And I noticed that you described his cough as severe, and you still remember how severe it was, his cough. And actually, it was the same for my patient. Her cough was really a severe cough, something you don't easily forget. Yep. So thank you, Dr. Abdullah. Thank you for sharing. Questions in the chat. Why we give budesonide, not ipratropium, with salbutamol? Budesonide inhaled corticosteroids mainly for its anti-inflammatory effects. Another question, what's the role of beta agonist with normal peripheral pulse oximetry? Okay, the pulse oximeter was normal, but because the chlorine gas is irritant, it induces the bronchoconstriction, so you need beta blocker for bronchodilation. Okay. So the message that take-home message from this case is, what is the role of magnesium sulfate in such cases? For this case, no specific role, no role for it. So the treatment mainly supportive, oxygen, inhaled bronchodilators with or without systemic or inhaled steroids. Okay, so the take-home message from this case is that we need to educate our families, our friends, our patients that mixing of cleaning products is dangerous and should be avoided, especially bleach with toilet cleaners. Okay, this is a reference if you want to read more about chlorine gas. And moving on to our next case. Okay, from the photo, what do you think the next case will be about?
Psychiatric patient.
Yep, psychiatric patient, suicide, depression. Yep, the majority mentioned suicide, depression, generalized anxiety disorders. Yep, major depressive disorder. Burnout, okay, I like burnout, okay, mental illness. Okay, suicide. Okay, so this is a case, a 50-year-old lady, new patient in our PHC, so we don't know her before. Came with no ID card and she was complaining of nausea and vomiting. And she came to us on the first week of lockdown, on the first week of the 24 hours lockdown. And as you know, all that lockdown was associated with increase in the risk and in the severity of mental illness. Okay. So the patient was hardly talking, with no facial expressions at all, and she was avoiding eye contact. And what we get from her that she is a known case of depression on treatment, and that yesterday she ingested 12 paracetamol pills in an attempt to end her life. So, and since we cannot take much history from her, we went on to the physical examination. Her vitals was normal and systemic examination unremarkable. She was thin, her BMI is 18. So this is a case about paracetamol overdose. I found this study done in Saudi Arabia in 2017. They collected the data from Ministry of Health Call Center 937 and from hospital reported cases of overdose. And they found that during 2000 accidentally detectives and 1,042 cases of accident. The most common ingested chemicals were analgesics, followed by vitamins, antihistamine, antibiotics, and oral bronchodilators. And of the accidentally ingested analgesics medication, acetaminophen, paracetamol was the most commonly ingested, followed by non-steroidal anti-inflammatory drugs. And this is not only in Saudi Arabia. I found data from other countries, US, Australia, United Kingdom. In all these countries, paracetamol was the most commonly ingested analgesics used for overdose. And it makes sense because it's available everywhere, almost you can find it in any home. So if the patient wanted to overdose on it or to commit suicide, it is there in the home. No need to go outside to buy it or anything. It is readily available, which makes the risk of overdose higher than other medications. When we have a patient with a potential paracetamol overdose, we need to calculate the total ingested dose to know, does it reach a paracetamol toxicity or not? Okay. Like for example, if a mother told us that her child whose weight is 10 kgs ingested 2 pills of paracetamol, our action would be different than when she told us that her child ingested 10 tablets of paracetamol. It all depends on paracetamol toxic dose. Okay, so when we have the patient, we need first to do risk assessment to guide management involving an accurate history about the dose ingested, the formulation, is it an immediate release or a modified release formulation? Was it an acute one-time ingestion, or was it a staggered or a repeated therapeutic ingestion? And timing of ingestion is very important. And whether there's any other symptoms like abdominal pain, whether there is any symptoms like abdominal pain, nausea, and vomiting. And you know, the main outcome of paracetamol toxicity is hepatotoxicity, and the level for hepatotoxicity is 200 milligram per kg or more than 10 grams within 24 hours. So, did our patient ingest a toxic dose of paracetamol? Her weight was 50 kilograms, and she ingested 12 tablets of paracetamol 500 milligrams. So can you calculate, can you tell me if she ingested a toxic dose of paracetamol or not? Okay. So the toxic dose is 200 milligram per kg or more than 10 gram within 24 hours. Okay, so if we calculated, she took 12 tablets of 500 milligrams, so total she took 6,000 milligrams. And divided by her weight, she took 120 milligram per kg, which is less than the toxic dose, less than 200 milligram per kg. So does it mean that she doesn't need us to do anything for her, since she didn't reach the toxic dose of paracetamol overdose? So what do you think? Is our patient safe or not? May need LFT, okay. But since she didn't reach the toxic dose, no need for any evaluation or observation. Yeah. But okay, majority said she needs to be observed. So therapeutic observation, not safe. Not safe, she might repeat ingestion. Yep. The time reassessment. She is symptomatic. Okay. Okay. If this was another patient, if this was a patient who took the tablet by mistake, not as a suicide intent, nothing further should be done to her. As long as the ingestion was below the toxic dose, if the patient took it accidentally, there is no need for any further evaluation. But our patient took it for suicide, and all patients who ingest medication as a suicide attempt should be evaluated as having a toxic exposure, regardless of their stated amount. We are not really sure if she took 12 or 20 or 30 or 100. We can't depend on what they're saying. So patients who take medications as a suicide attempt, we don't need to calculate even if they reach a toxic dose or not. We should consider them immediately that they are having a toxic ingestion. So now we will speak generally about management of drug overdose, and then we will go to cover paracetamol overdose. So when we have a patient with drug overdose, the first step would be, as usual in any emergency, is a basic life support ABC, airway, breathing, circulation. As some of drug overdose might cause respiratory distress, some drugs can cause circulatory collapse, hypotension. So the first step in evaluating any possible drug overdose is basic life support. And the second step, as we mentioned, chlorine gas exposure. For any exposure, we should do decontamination. Try to remove the toxic exposure as much as possible. So decontamination for orally ingested drug can be done by a single dose of activated charcoal, and it is the gastrointestinal decontamination treatment choice in most medication ingestion, but should be only used within 1 hour of ingesting a potentially toxic amount of medication. So it is used only if the patient comes to us within the first hour. Minor exception in some medication, but generally only within the first hour, because after 1 hour, all of the medication is almost absorbed to the body. Gastric lavage or whole bowel irrigation should be considered for ingestion of medications that are poorly absorbed by activated charcoal, such as iron and lithium. For these medications, activated charcoal is not effective, so patient might need gastric lavage. And also for sustained release formulations and enteric-coated tablets, activated charcoal is not effective. And this is the activated charcoal we have in our centers. It's a powder, and it comes in a bottle of 100 grams. Sorry, I don't know why I cannot show the photo. So just the photo was just summarizing activated charcoal. So it is a powder. We mix it with water. It can be mixed with juice for children to make the taste more palatable. It is used within 1 hour of toxic ingestion. It is contraindicated if the patient is comatose, disoriented because of the risk of aspiration. It is contraindicated if there is causative agent ingestion because it doesn't work with causative materials, and also those patients usually need endoscopy, and activated charcoal would obscure gastric walls and will make it impossible to visualize it during endoscopy. And also we said that we cannot use it for some medications such as iron, lithium, alcohol, overdose, and it should not be used if there is suspicion of bowel obstruction. And generally, we said that it is used only within the first hour, 60 minutes of ingestion. But in some medications, we can use it up to 4 hours, and we can give a second dose after 4 hours. These medications include phenobarbital and carbamazepine, because these medications, as a side effect, they cause delayed gastric emptying. That's why we can use it up to 4 hours. And also these medications have an enterohepatic circulation, so activated charcoal might be of benefit up to 4 hours and after that. Okay, how do we calculate the dose? I don't know really why I cannot show you the photo, because all the information was summarized nicely. So the dose is, as you see, the bottle here. Yeah. The bottle here is 100 grams. For adults, the dose is 50 to 100 grams. So they might need either half the bottle or the whole bottle dissolved in water. For infant less than 1 year, it is 12.5. And for children, it is between 25 to 50 grams of activated charcoal. Okay, so we said that the management of drug overdose, the first step is ABC, the second step is decontamination, and the third step is antidote is possible. Not all drug overdose have antidote, but if the drug has antidote, we should be prepared to give it. So going back to paracetamol toxicity, the antidote for paracetamol toxicity is N-acetylcysteine, and survival of paracetamol overdose.
I'm sorry, Dr. Afrah,
yes,
to interrupt you. We have 2 questions here,
yes.
3 questions actually. Role of 200 milligram per kg, does it apply to PD as well? And then there's another question that says, how can we calculate the dose of the charcoal? And the last one is, what about the amount of water to be used?
Okay, thank you, Vicky. So the role of 200 milligram per kg for children, I found different references. For some, they stated it is 150 milligram per kg for children. Other references stated that it is 200 milligram per kg. If you want to go towards the safer approach, go with 150 milligram per kg. Calculating the dose, as I mentioned, that 50 to 100 milligram for adults, 25 to 50 for children, and less than that for infant less than 1 year. What about the amount of water? Nothing specific. You just dissolve it like in a cup of water. If they were not strict about exact amount, just a cup of water. So going back to N-acetylcysteine, so the survival of paracetamol overdose is considered 100% in cases receiving N-acetylcysteine within 8 hours of exposure. Efficacy declines after this point. So we should aim to treat paracetamol overdose within the first 8 hours after exposure. That's why knowing the exact timing of exposure is important. So this is a simplified algorithm to the treatment, and this applies only to a single ingestion of overdose paracetamol immediate release formula. There is a different algorithm for multiple ingestion and for extended release formulation. So we start if there is a concern for possible acetaminophen intoxication and non-ingestion of acetaminophen more than 8 hours ago. The action should be to start N-acetylcysteine immediately, because as we mentioned that after 8 hours, its efficacy starts to decline. So if the patient presented to us after 8 hours, we start N-acetylcysteine immediately. We don't have any further time to waste. For 8 hours. If we have time, we'll check ALT, liver enzymes, and we will check paracetamol level. If ALT is elevated, we will give N-acetylcysteine regardless of paracetamol level. If ALT normal and paracetamol level is below treatment line, no further treatment is needed. But if acetaminophen level is above treatment line, we should start also N-acetylcysteine, even if liver enzymes is normal. And to help us with deciding the level for treatment, we have the Normogram. This is the Normogram. We check paracetamol level 4 hours after exposure and see if it is more above the red line, more than the threshold for treatment, patient should be started on N-acetylcysteine. But if the patient presented after 8 hours, we start N-acetylcysteine we start it immediately while we draw paracetamol level and labs and wait for results. Okay, so our liver enzymes and her creatinine also was high. She was having an acute renal injury in addition to the hepatotoxicity. So remember the slide when I told you that patient told you that he overdosed as a suicide attempt. Don't take their word. Our patient, she maybe took another medication in addition to paracetamol. As you know, paracetamol mainly causes hepatotoxicity. Maybe she took a non-steroidal anti-inflammatory drug in addition, or any other medication that caused her acute renal injury in addition to the hepatic injury. And although we've calculated her level that she stated 12 tablets as a non-toxic level, having a liver enzymes elevation means that she definitely took a higher dose than the one she stated to us. Our patient stayed in the hospital for 2 months, but luckily she, Okay. Sorry, I apologize. I had a problem with my connection, so I had to use my iPad instead of the laptop. Okay. Okay. So going back to my patient, luckily that my patient survived after being admitted in the hospitals for 2 months. She was discharged back to her baseline. Okay, so some questions here. Okay. So there's a question. If the patient ingested untoxic dose, do we have to give an acetylcysteine also? No, if the patient ingested the dose by accident, not as a suicide attempt, and you are sure about the amount ingested and you calculated and it didn't reach the toxic dose, no need for an acetylcysteine. Okay, we will go back. Okay, so we finished with our drug overdose case. Do you have any questions, anything else you would like to add? Okay, so we will move now to our third case. I think we're running out of time, so I'll try to speed things up. Yes, just before moving to the next case, since we were talking about oral injections, every now and then we have like a relative, a mother in the clinic, or someone we know is asking about children. As you know, children eat all different sorts of materials, anything they can put it in their mouth and they enjoy eating. So what about these materials? What should we do to the patient when they ingest these materials? Is it toxic or not? So I found this website. It's called from Illinois Poison Center, and they had a whole section called My Child Ate, and then they list a long list of weird stuff that children might eat. And they mentioned the toxicity level, possible symptoms, and what to do, like Vaseline crayons, usually non-toxic, minimally toxic, silica gel, usually non-toxic, but it's a choking hazard. Cigarettes, it's toxic. What should parent do? We can instruct our patient to call 937 Ministry of Health hotline if they have a possible poison exposure. So moving on to case number 3, what do you think the case would be about? Yep, allergy, anaphylaxis, hypersensitivity. Okay, so question before we go to the case. There are 8 food groups that are known to cause 90% of anaphylaxis cases. Do you know what are these groups, food groups? So it's called the big 8 of anaphylaxis. And to help you, it is the food that by law required to be that if on food label, that if we have it in the food, it should be labeled that this food contains this, this, and this. Okay. Egg, milk, nuts, seafood. Yep. Soy, sesame, egg, fish nut. Okay. These are the top 8 food allergens, as you mentioned: cow's milk, soybean, peanuts, fish, shellfish, eggs, tree nuts, and wheat. Okay, so our case is 7-year-old boy. His non-case bronchial asthma, and he had multiple food allergies, presented with shortness of breath, wheezing, generalized skin rash, and lip swelling that started while eating lunch on Eid al-Adha day. I was covering urgent care last Eid vacation, and so this boy, he was having lunch. And as you know, يعني غدانا يوم العيد غالبا وليمة لحم. And there was كان في كزينة في الصحن كان في كاجو. And الولد allergic to cashew, but he knows that he's 7-year-old and he is aware of that. فشاله مسك الكاجو شاله وأكل باقي الرز. And that alone, touching the nuts and eating food that was touching also the nuts was enough to precipitate allergic reaction for this boy. So patient with nut allergy can have the allergic reaction not only via ingestion, but also via touching the nuts or eating something that have touched the nuts. And that's why for food labels, you will find this sentence also, that it was manufactured on equipment that process peanuts. So people with nuts allergy should avoid also consuming these foods. So again, this is an emergency case, so we will start by airway. Patient can't talk but cannot complete a sentence. Breathing, he was tachypneic, respiratory rate 24, O2 98%, and chest auscultation showed wheezing all over the chest. And circulation, the pulse was 106 BM. Blood pressure, he was slightly hypotensive for his age. Blood pressure was 96/58. So anaphylaxis is a life-threatening systemic reaction, usually occurring within 1 to 2 hours of exposure to an allergen. Most common symptoms are urticaria, shortness of breath, and mucosal swelling. And coexisting asthma, mast cell disorders, older age, underlying cardiovascular disease, peanut and tree nut allergies, and drug-induced reactions are associated with severe or fatal anaphylactic reaction. So my patient had 2 risk factors for severe anaphylaxis. He had asthma and he had nuts allergy. Common triggers for anaphylaxis include medications like antibiotic, most commonly beta-lactams, non-steroidal anti-inflammatory drugs, chemotherapy, biological agent, and ACE. Foods, insect bites, and there is 1/5 of cases have idiopathic anaphylaxis. No trigger could be identified. So the recommendation for practice is to administer intramuscular epinephrine into anterolateral thigh as the first-line treatment of anaphylaxis. Use of antihistamines, corticosteroids, only as adjunctive therapy after the administration of epinephrine, and fluid resuscitation if the patient is hypotensive. So for the management, the patient should be put in a supine position with lower extremities raised, monitor and support airway, breathing, circulation, and administer intramuscular epinephrine to outer mid-thigh, either via EpiPen, the auto-injector, or what we have in the center is 1 to 1,000 epinephrine dilution at a dose of 0.1 milligram per kg, maximum 0.3 milligram in children and 0.5 in adults. So after the first dose of epinephrine, if the patient is improved or resolved, we can give oxygen. We should establish 2 large IV lines for IV fluid, antihistamines, steroids. And if the symptoms improved, we should evaluate the patient. Is he at risk of severe anaphylaxis or a biphasic reaction? Some patients improve initially, and then they have another phase of anaphylaxis. So they will need a prolonged observation. If the patient has a severe anaphylaxis or a risk factor for severe anaphylaxis, like my patient, he should be referred to a higher level of care. If risk factors are absent and the patient improved, he should be observed at least 4 hours and discharged with epinephrine, EpiPen, anaphylaxis action plan, and referral to immunologist or allergist if they are not following with one already. If the patient not responding to epinephrine, we can repeat the dose of epinephrine every 5 to 15 minutes with other modalities. If he is hypotension, we would start IV fluid bolus. And for patients with reactive airways disease, wheezing or bronchospasm, we would give a nebulized beta agonist. And then the patient on beta blocker might have refractory anaphylaxis, so this patient might need glucagon IV and should be transferred to a higher level. So can we prescribe autoinjectors from the BHC? Before we didn't have them, but like a month ago, we got like a memo from Ministry of Health estimating our number with number of patients with allergy, because they have a plan to provide it to them soon. So our patient received 0.3 milligram of epinephrine IM. So it is available, the epinephrine vials available in our center, so we can use them if we don't have the epinephrine autoinjector. So our patient received 0.3 milligram epinephrine. He was given hydrocortisone 50 milligram IM and promethazine antihistamine 12.5 milligram IM, in addition to nebulization of salbutamol. Okay, he improved, but again, he refused to stay for observation and signed DAMA. But the parents were well educated and they lived nearby the center. So they stated that if the child deteriorated, they can bring him quickly back to the center. So, and this is the epinephrine EpiPen, and all patients with anaphylaxis should have one. And as you can see here, what's written here, because every second counts in treating anaphylaxis. Take-home message. One of the problems we face in our society, we are generous in offering food. بشكل عام إحنا نعزم واجد على الفود. It is in our culture, and أشوفها كثير مرات في الكورنيش، في المجمعات، حتى في الويتنج اريا في الهوسبيتال. ممكن جماعة ياكلوا، يجيهم طفل حتى ما يعرفوه, and they offer him food, and this food could be dangerous for him. So we need to spread awareness. Never give a child any food without their parents' permission. They might have allergy to it and it might kill them. So we need to spread this message. And another point is that we need more legislations. For example, in some countries, it is prohibited to bring any type of nuts into school, whether in the cafeteria, school cafeteria, or from student lunch boxes. So I think we need legislation like that. We need to have EpiPens available, and all schools should have EpiPens. No nuts in school here too. Maybe in some private school, but in government school, there's no rules for that. Okay, one last point related to the topic of anaphylaxis. What do you think now? Our next talk. Yep, ACE-induced angioedema. Okay, just one slide regarding to it. With ACE-induced angioedema, the lack of response to adrenaline, antihistamines, steroids is typical, and it's due to the condition being related to accumulation of bradykinin and not histamine. So treatment of ACE-induced angioedema, discontinuation of ACE, of course, and not to prescribe ACE against to the patient. And we might try fresh frozen plasma. Before they said maybe icatibant might be helpful, but then further studies showed that is not helpful for the patient. So treatment is mainly supportive for ACE-induced edema. Okay, and this is a reference for anaphylaxis. And I don't know, do we have a time for the last case or not? It is already 8:05.
It is up to the participants. If they're willing, excuse me, if they're willing to listen, I am willing to wait and listen too.
Okay, I'll try to make it a quick. Okay. What do you think this case is going to be about? Yep, something related to sugar. At the start of my presentation, I told you I will not cover common problems, but because Ramadan is approaching a month away from now, and we have a lot of hypoglycemia cases in Ramadan, so I would review it quickly. So a bystander, found a woman in the parking lot of our center and brought it to the attention of PHC. She was brought inside. She was in a confused state, sweating, shaking, and it was difficult to take history for her. So when we can't take history, we jump directly to ABCs and evaluation. Her vitals was okay, but her random blood sugar was 32. Okay. So what is the management of hypoglycemia? The first step as any emergency is to assess ABC, level of consciousness, and ability to drink. Is the patient able to take oral food without risk of aspiration or not? And for patients in hospital, we need to send sample to the lab for verification. Second step, if the patient is conscious and able to drink, we have the rule of 15. So we give 15 grams of oral glucose, for example, half cup apple juice, 1 tablespoon of sugar dissolved in water, or 1 tablespoon of honey. And we repeat blood glucose after 15 minutes. And if blood glucose is still less than 72, so the patient is still in hypoglycemia, we need to repeat the process 3 times until the glucose is more than 72. And then we need to give a snack of 15 to 20 grams of complex carbohydrates, such as 1 toast. So if the patient is able to drink, remember the rule of 15. Okay. If the patient is unconscious, but there is already an IV access, or we can rapidly secure IV access. For mild cases, we would administer 25 ml of 50% dextrose over 1 to 3 minutes and recheck glucose in 5 minutes. Because it's IV, we don't need to wait for 15 minutes like oral ingestion. So because it's IV, we check the blood sugar in 5 minutes. And if the glucose is still less than 72, we repeat the process until we have the blood sugar more than 72. And for severe hypoglycemia, like our patient, if glucose less than 45 milligram per deciliter, we administer 50 ml of the 50% dextrose IV. And again, repeat the process repeat checking in 5 minutes until the blood glucose is more than 72. If we don't have a secure intravenous access, we can use a glucagon, and we administer 1 milligram glucagon. In the center, we administer it intramuscularly. For patients at home, they can use it subcutaneously, but in the center, we administer it intramuscularly for a quicker action. And then we repeat blood glucose in 15 minutes, And if it is still low, we can re-administer another glucagon dose and repeat the process until the patient is out of hypoglycemia. And when the patient is conscious and able to eat, he should have 30 grams of complex carbohydrates, such as 2 to 3 toasts. And this is the glucagon. All patients on insulin should have a glucagon at home and should be trained themselves and their families, their companions should be trained on how to use it in cases of emergencies. And we can prescribe the glucagon via wasfati. Yep. Is the algorithm for diabetic patients only or in all hypoglycemic? All hypoglycemic cases should be treated in a similar pattern. Okay. After stabilizing the patient, step 3 is assess and manage the precipitating factors and adjust dose of insulin and other hypoglycemic agent in order to avoid future hypoglycemia. Our patient, we found out that she is taking insulin by herself without a prescription. She is diabetic on metformin only, but she doesn't like to commit to a diet. So she take insulin with the impression that when she take insulin, she can eat whatever she likes. So she had repeated attacks of hypoglycemia before, all because of the same reason. So we spent a lot of time with her, educating her about the risk of hypoglycemia, the risk of using insulin without proper prescription and follow-up. What about in children? For children, for adults, hypoglycemia is diagnosed when glucose is less than 70. But for children, it is diagnosed when it is less than 60 milligram deciliter. And treatment is essentially the same. If the patient is conscious, asymptomatic, they should eat. If they have impaired consciousness, convulsion, or coma, they should receive 10% dextrose, normal saline 5 ml per kg, and the process should be repeated. And if there is no response or no IV access, they should receive a glucagon. If weight less than 20, they will have half the dose, 0.5 milligram. If weight more than 20, they will receive 1 milligram. Okay. And what if we don't have D10 in the center? Like in our center, we have only D50. We can easily dilute D50 to make it a D10, and this is the instruction: 10 ml of D50 with the rest normal saline. We will get the 10% dilution. Those are differences. The information mainly from Ministry of Health guidelines. On Ministry of Health website, there are 2 guidelines, one for diabetic emergency and the other one for hypoglycemia in infant and children. And that concludes my presentation. Thank you all.
Thank you, Dr.
Most welcome. If you have any question, anything you'd like to discuss, the floor is open.
Apparently, there is no questions.
Yeah.
Thank you, Dr. Afrah, for the cases. Well presented and really practical. We enjoyed being with you tonight, Doctora. Thank you so much.
Most welcome. Thank you for your attendance. Thank you all. Just one question there. When can we say it's a hypoglycemia? For adults, if blood glucose less than 70, and for children, if blood glucose less than 60 milligram per deciliter. In non-DM patients, it's the same. Same values, same readings. when to refer patient with hypoglycemia. If the patient is not improving on treatment, if he is having convulsions, coma, not improving, we need to refer them. And as you know, there are some medications that increase the risk of refractory hypoglycemia, such as beta blockers. So those patient also might require hospital referral. How to prepare epinephrine if we don't have EpiPen? The epinephrine formulation photo that I showed you is the one that we have in the center. Just one moment. Just came out. Okay, so epinephrine. Okay, this is the epinephrine available in our center. It is 1 to 1,000 dilution, so this is ready to use. We give the dose directly from this ampoule. We calculate the dose, whether it is 0.3 maximum for children or 0.5 maximum for adults, and given intramuscular. Okay, you're most welcome. If no further question, we would conclude our session tonight. Thank you for your attendance and participation. I really enjoyed presenting the cases to you. You were a nice audience. Thank you all.